Good morning, everybody, or good afternoon, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor for BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by MRO Health. And it is titled Insights for Navigating Value-Based Care Policy and Regulatory Trends in 2025. So, very excited to hear from our speakers today, who I will introduce momentarily. A few items of note before we begin, just some housekeeping things. Everyone has joined today in a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera. Those things have been done for you. However, we are going to have a time at the end of the session where for Q&A. Well, we would love to hear from you. So if you have a question at any point during the presentation for either of our speakers or just in general, use your control module. There's a place for questions on there, and you can drop those questions in. We're going to get to as many as we can in the allotted time. If for some reason we don't get to yours, don't worry. Someone will reach out via email to make sure we answer that. We're also going to have a few polling questions, so you can play along at home, and that'll be fun. So I'll walk you through when we get to that point. And I think, last thing is everything is, or the session is being recorded today. So what's going to happen is when we're done, you'll receive an email that will have a link to where you can download the slides from today's session. You can rewatch the recording, share that with colleagues and friends, and we hope that you do. So, all right, well, without further ado, wanted to briefly introduce our speakers today. With us, we have Mr. James Pelletier, and he is the National Director of Provider Quality at MRO. And we have with us Ms. Maria Alexander, and she is the EVP and partner of Coral Health Partners. So welcome to you both.
Thank you. Thank you very much. So, as Garrett mentioned, we're here to talk about some of the new regulatory trends and things that we might be able to anticipate going into 2025 and beyond, and perhaps things that we might be able to learn from our past. Again, my name is James Pelletier, and I am National Director of Provider Quality for MRO. I have about 20 years in healthcare technology, with about 12 of the past, the past 12 years, I guess I should say, really focused on population health initiatives. So my area of expertise tends to fall in, the data behind healthcare, data aggregation, analytics, patient engagement, care coordination, and those types of use cases. I live in the very northeast part of the country, and been with MRO for the last 2.5 years now. So happy to be with you, and happy to be joined by Maria Alexander with Coral Health Advisors. Had an opportunity to meet Maria several times, and I've always had wonderful discussions about healthcare in general and value-based care. And
Sorry, James, you froze there for a minute for me. I don't know if it's just on my end, but was
okay.
that an opening for me to introduce myself?
There you
Yes,
go.
I'm sorry.
Great. Well, happy to be here with you, and looking forward to the discussion. Coral Health Advisors works in the public and private sector space all around trying to make healthcare better. So we do a lot of work with accountable care organizations. That's the part of the business that I lead, and really work with our clients around navigating various regulations and compliance questions, but also really working in the operational space and leveraging my and the team's experience both on the government side as well as on the delivery system side. So happy to be here today and excited to get into the discussion.
Absolutely. And one of the things that I appreciate is both your provider experience and your government experience in policy making and being kind of on the front lines, both for providers and patients, as well as, for helping facilitate that at the government level. And, that's all obviously an evolving process. And one of the constant things that I think, see in healthcare is change. So, and that's really kind of part of what we're here to talk about today, is some of that potential change and how we're evolving. So, again, that background and your expertise is valuable to the discussion. So, moving beyond introductions, we do want to start out with a poll question and get you guys involved. I want to say, as Garrett mentioned earlier, I know Garrett's going to jump in here and get this question asked, but add as much information as possible in the chats. We have a lot of interaction opportunities where we want to hear from you. So whether it's a question or a comment, or you're answering E in this question and you want to add something that we hadn't considered, please feel free to do that as we go. Garrett?
Great. Yeah, very good. And so you should see this up on your screen right now. This is a polling question. These are anonymous, so feel free to answer honestly. And it's just kind of fun. We'll be able to show you where you stack among your colleagues. Um, and yeah, the last question it says, or the last choice is something else added to the chat. You can add that to the chat. If you have a question, however, for the speakers, go ahead and there is a different place for actual questions. So I know it's a little bit confusing. But this question, again, what challenges do you anticipate in meeting future requirements in value-based care? And looks like we've got some answers still rolling in here. Is it data collection or reporting complexities? Integration of disparate data sources? Addressing health equity through reporting? Lack of standard metrics across organizations? Or something else? Add that to the chat. Okay, it looks like most of the answers have come in, so we're going to give it another maybe 10 seconds here, and then we will close it out, and then I will show you the results. Okay, all right, looks like, okay, about 5 seconds, and then we will close it down. 4, 3, 2, oh man, they keep coming in. I hate to close it off, but we need to keep rolling. So here we go. We're going to close it down. All right, so James, you are not able to see the answers, is that correct?
Correct.
And Maria, you are you able to see it, right? Okay, so I'll
I
just
am,
read them
yeah.
off real
So
quick. Oh, go ahead, Maria. Do you want to just read them
yeah, so
off?
I was
And
just gonna say, so James, it looks like we got responses really in all the categories, and only a couple people said something else. So you did a nice job with the topics that were likely to to create some interest. So the um, the highest percentage was in the data collection and reporting complexities. That was rated highest. Very just two more people voted for that than for integration of disparate data sources. So those two lead the way, with lack of standardized metrics coming in a close third, and addressing health equity coming in fourth. But really, all four of those got more than 20 or more people voting for them. So looks like all of the above is the answer here.
Got it. So there are multiple challenges, multiple concerns, and obviously we want to kind of gauge where people's thoughts process was going into the webinar. I don't know that we'll change your answers perhaps by the end of this webinar, but maybe if we had added all of the above, that would have been by far the biggest answer for the group. So luckily, these are all kind of topics and subject matters that we're planning to talk about today. So I think that is a good lead-in. We do want to introduce the folks on the call to MRO, who is our sponsor and obviously the organization that I work for, and tell you a little bit more about how we're helping value-based care organizations, mainly on the provider side, but also with payers and other groups like medical societies and things like that. I think what you should know about MRO is that we're really synonymous with clinical data exchange, and what we do is really help providers in a variety of different areas. One of the ways that we help with clinical data exchange is with respect to the incoming requests that providers receive, both from patients, payers, as well as in some cases lawyers and workman comp organizations and things like that. We've been around for a couple of decades now, best in class for multiple years. Obviously, as you can see, have achieved many milestones and won awards. We are NCQA validated as a data aggregator validation tool. Something that's fairly recent over the last couple of years and something that we're very proud of. Top places to work multiple years in a row, including for 2024. So that's just a little bit about, MRO and sort of where we come from in the healthcare industry. What I tend to focus on here at MRO is the quality reporting aspect, which again, for value-based care organizations like yourself, tend to be part of your focus on an ongoing basis. We have a lot of really, really great experience helping organizations get credit for the quality of care that they provide. So with respect to quality reporting, and specifically for MSSP organizations that are going through a big change right now, we have an end-to-end solution that helps solve for a lot of the risks involved with not only providing great quality of care, but again, getting the credit that you deserve. So we have a foundation of innovative technology and services built around ensuring that we're getting good data and accurate data with respect to services provided. And one of the things that we'll get into as we go forward is that challenge associated with all the different technology and EHRs that providers tend to use, and having the ability to be able to utilize that data and combine it with other technologies in a meaningful way and understand your patients in a much more granular way. So combining things like lab systems with EHR systems and practice management systems and patient reported outcomes. There's a lot of mapping involved with doing that right. And of course, the need to translate all these different nomenclatures and languages that these technologies speak into a common language for the purpose of improving patient outcomes, improving your quality reporting, and the ability to, again, to provide data to providers at the point of care that will help them make better decisions on the patient's care itself. So that's kind of, in a nutshell, MRO. Performance Pathway is our solution for value-based care organizations. And what you can think of with MRO is all those different quality measures that we're held to, HEDIS measures and cost containment measures, utilization, and things like that. All those different data points go into our clinical data repository for the purpose of, again, providing great patient outcomes. So moving into our topic, which we're here for today, and again, sprinkling in a little bit of our subject matter expertise, both on the consulting side with Maria and the solution side here at MRO. Some of the subjects that we wanted to address in the call today was, sort of the elephant in the room, which is a big change happening over the last couple of months, which is a change in administration. We have a Republican-controlled House, Senate, as well as presidency. Not intending to get political by any means, I don't think, neither me or Maria. But again, just sort of understanding some of the differences that we've seen in the past, obviously with the Trump administration and coming out of the Biden administration. What are the things that we might see going forward, and how is that going to potentially impact your business? So in subject matter number one, with the political landscape being what it is, and a focus on efficiency that we're seeing from the government, there are things that I think that have been synonymous with both parties over the course of the last decade, or maybe a little bit longer than that, and that is their overall views on value-based care. I think growth of value-based care has been important to both Democrats and Republicans. The use of technology within value-based care tends to be a constant that we're hearing, again, and a push towards utilizing certified EHR technology and creating some level of standardization there has been something that we've seen consistently, I think, over multiple administrations. Democrats, I think, tend to focus a little bit more on the growth of these programs, where I think maybe Republicans tend to focus on cost containment and and maybe less government intervention. But overall, I think, again, growing value-based care arrangements, increasing risk and incentives, aligning incentives with risk is a continued push over the last, again, couple of years and going into 2025 as well. Love to get your thoughts on that, Maria, being a little bit closer to that than maybe I have in the past. What are your thoughts on the change of administration at this point?
Yeah, I think definitely agree with you on the continued focus on value-based payment, value-based care. I don't think that goes away. I don't think ACOs go away. But that's not to say that there won't be changes, or just that the fact that a change in administration means change, and so like things are gonna take a little longer, or different politicals are going to be in place, and some of that stuff just
Mm-hmm.
just comes with some changes. But I think to get a little more specific, or some examples maybe, I think we have seen in the past, with changes in administration, that sometimes programs get renamed, right? Some of it is a branding exercise or a rebranding. You think about the geographic and professional direct contracting model being rebranded to ACO REACH and having some changes to the program. But at its core, that kind of advanced risk-focused ACO model started in the previous Trump administration and continued into the Biden administration.
Mm-hmm.
MSSP, another example, that's a congressionally mandated program, but it doesn't mean it's static, right? We see changes within administrations, and we see changes across administrations. If you think back to the prior Trump administration, we saw a restructuring of the program, and where they, called it Pathways to Success. That's when we moved from tracks 1, 2, and 3 into the basic and enhanced tracks. There was definitely, like you said, more of a focus around like pushing organizations into risk a little bit faster, and maybe less of a focus around broadening the group of organizations that were participating. But again, the core of the program really stayed the same, and existed throughout both administrations, and we expect it to continue. So I think for sure that doesn't mean there won't be changes to those programs or changes to other CMMI value-based programs that people may be paying attention to.
Mm-hmm.
But we certainly see a continued focus from the new administration around value-based care. The political appointees that have come into CMS tend to be proponents of value-based care. So we expect to see that continue, and like I said, expect to see some new models coming out as well. So certainly good time to be paying attention and be ready for changes, but I don't think it's cause for panic for those who are really working in the value-based payment space. I think that's here to stay.
So if we were speculating, stay the course, meaning, that for largely there will be change, but for the most part, the models will continue to be focused on the things that we just mentioned, the technology, the cost containment, et cetera. I know that MSSP ACOs are trending upward in terms of the number of MSSPs that are coming into 2025, although I don't think we have a final number yet. Do you have a gauge as far as the ACO REACH program, how that's going kind of early on, and sort of how people are reacting to participating in that program?
Yeah, so that program is actually now in its second to last year. So it's scheduled to end in December of 2026. Obviously, there's still 2 performance years left, but I think we've certainly seen some change over time with some organizations that have dropped out or decided to move to MSSP. There's been a big range of performance, right? Some organizations that have had huge windfall savings, and others who have had really significant losses. So it's not a one size fits all, like none of these programs are. You join and you're guaranteed to be successful. But there's a solid cohort of organizations that have remained in ACO REACH and that are very eager to see whether this administration will extend the program or what comes after REACH. So
Right.
the initial evaluation results from CMS, which are sort of distinct from the annual performance of the ACOs, but are sort of more of a there's a control group that they're looking at and they're saying, did this program save money overall?
Hmm.
Those early results have not been particularly strong. And so I think there were signs that CMS would likely not extend it. But I think there's maybe some more optimism with this administration that it would be extended a little bit. I think given that it was originally a Trump administration program, so we'll see if they extend it. Um, or even if they don't extend it, sort of see what comes next in terms of new models for organizations that are really looking for that more advanced risk track. And I think one thing in particular I'd say about Reach is that it has a few different tracks, and one of them is this track that's focused on high needs populations. So a lot of ACOs that are serving a particularly frail population with multiple chronic conditions, sort of a PACE-like program, but in the Medicare fee-for-service space. And I think across administrations, regardless of who's in office, who was going to be in office next, I think there was going to be interest in continuing to expand accountable care models to those populations. A lot of folks living in long-term care settings, things like that. And so wouldn't be surprised even if Reach doesn't continue to see more opportunities for folks in the sort of high needs or long-term care space. So I think good things to be on the lookout for there.
Yeah, that's a good summary. I think it's an evolution. So again, the name may change, as you said, but hopefully, each time we change, we get better. So that maybe is one of the things that we can look forward to, is that the next iteration gets better and better, and really, I think again, better aligns incentives with the risks that we're asking providers to take, and that's not always easy. Um, but that's obviously, again, the direction that we see CMS typically going. So transition into quality reporting, and one of the things that I know came up in the poll earlier, we are seeing a transition specifically for MSSPs to report on a much larger volume of patients compared to what they have historically been reporting on, and ultimately what determines the shared savings that these ACOs are getting. Of course, I'm talking about ECQMs. There are multiple methods of reporting, but ECQM stands for Electronic Clinical Quality Measure. And one of the big changes here is that rather than it being a manual process that is consuming ACO's time in the February-March timeframe, where they're running around and kind of scrambling to figure out what patients are to be reported on and where does the data live for all these different patients that have been seen throughout the network. That's obviously very challenging for ACOs, since they're working with a number of different providers, multiple TINs, multiple EHRs, and those EHRs and those technologies are not necessarily controlled by the ACOs. And so this evolution is requiring integration with EHRs and requiring providers to provide quality data, either for their Medicare population or for their entire Medicare population, or for all patients in general, regardless of payer, whether it's commercial, Medicaid, et cetera. And that's a big change for organizations, again, compared to the manual process. But one of the things that it's doing, something that we mentioned earlier, is encouraging the use of technology within these ACOs for the purpose of, again, measuring and improving patient outcomes. But again, it's a problem that really requires technology to help solve, rather than, again, the process of manually submitting. And that's something that I hit on earlier with respect to MRO and how we can help ACO organizations, is the aggregation of those EHRs, all the data that's required for submission, and of course, measuring over time throughout the year, how am I performing, what providers are performing better than others, and what can I do in order to impact that. I see that change being the biggest change being the documentation gap, since we have to educate physicians on the new methods that we're getting graded on, and ultimately ensure that they're inputting data in the right fields to get credit for the care that they're providing. So we're limiting the quality measures for 2025 to 4 measures: depression, diabetes, hypertension, and breast cancer screening. All obviously important things that we should be doing for all patients. But not only do physicians need to provide those services, again, they need to document it appropriately to ensure that the quality reporting metrics that are being utilized accurately reflect that care. Beyond, I want to get your input, Maria. I always tend to focus on that aspect of the documentation gaps. It's where does my EHR expect me to put this data? Does it need to be structured data? And in some cases it does, in some cases it doesn't. But any other particular challenge that you see kind of going into that transition for MSSP ACOs?
Yeah, I think the other, very much agree with that challenge. I think the other one is really about for ACOs. It's one thing to do this if you're an ACO that's a single TIN, single EMR ACO, but that's not the vast majority of folks. And so I think the pulling together of information across disparate EMRs and linking, deduplicating, aggregating that information is not a small task in my experience. And so I think that's the other piece that's challenging. And I know you were talking most specifically about eCQMs, right? MIPS CQMs and Medicare CQMs give you a bit more latitude to not necessarily use the structured, it doesn't have to be structured in the same way. And so that's good news, but it also can mean way higher level of effort to collect the data, right? So there are other options than eCQMs, but just keep in mind that that you're not just talking about, it may be one thing to do sort of that kind of chart review for for the web interface for GPro, right? If you've got a sample of patients, it's sort of you've got the claims data on them, that kind of thing. But when you expand it to all patients, all payers, or even in the case of expanding it to Medicare fee-for-service patients outside your ACO, and not on a sample, right, but on the full population, that is a much more massive undertaking. And so it doesn't mean you have to do a manual chart review for all of those, but it's going to be a more manual process if you're not doing eCQMs, and we're talking about a really large population. So those would be some things I'd add, I guess.
I think that's a good way to put it, is that, the chart review process with the old way of doing things was something that was tenable. But, even considering the 3 different options for reporting, where you may only have to report on your Medicare patients, but the volume of that is still much, much greater than the 250 or so sample patients that were reported on before. And another good point I think that you brought up that I would love to reinforce is the fact that these ACOs are made up of provider groups that can be radically different in terms of their sophistication. There's still tons of 1 and 2 doctor practices out there that need to comply with obviously the new regulations, but also don't necessarily have the support that the larger medical group that utilizes Epic and has a big, IT development team at its disposal. So that is definitely something to consider as well. And I do think that there are solutions out there that can help assist even those smaller practices that obviously we do business with on a day-to-day basis as well. And one thing I wanted to mention, kind of tying into the last thing, we've seen lots of reiterations of the new quality reporting processes for MSSPs. It constantly gets reviewed by Congress, and there's a lot of lobbying that takes place with respect to delaying these requirements or changing the requirements and making them less or more strict. The flip side of that is that they tend to put incentives on the different options, so that the more, let's say if you take the eCQM option, they are typically going to incent you to do that, since it is a little bit more burdensome than Medicare CQMs. And the Healthcare Efficiency Through Flexibility Act is just the latest bill, I think, that's been introduced to Congress, one of thousands that I'm sure have been introduced, where we could potentially see a delay in these requirements. So for the last several years, we've been marching towards a 2025 deadline for this transition. But again, there's still some unknowns, obviously, with respect to the the legislature's decision on whether or not they're going to hear this new bill and adopt it into some other big healthcare policy change. So something that we're keeping an eye on, certainly, and I know other MSSPs are as well. Regardless of any decision to delay, I think that this challenge is not necessarily going away, whether it's this year, next year, or 2 years from now. Organizations are going to be incented again to be an early adopter, or if there are no changes, which is a high risk, getting started sooner rather than later to ensure that they are maximizing their performance and their shared savings.
Totally agree with that, James. And I think it's a question we're getting a lot from ACO clients of ours is both with new legislation that's proposed, but also just change in administration, right? Do we think, oh, maybe this is an opportunity, maybe they'll walk it back and it won't be a requirement for 2025. And of course, that's a possibility, right? It's always a possibility these programs evolve. But I think we're in 2025 now. And so a couple of years ago, I might have said to a client, yeah, you could keep doing web interface and just sort of start thinking about it, but don't fully, commit to getting ready for it, see how this shakes out. But I would not advise someone today to assume that they won't have to do this for 2025, because by the time, even if a change is made, by the time that change is made, it's,
Right.
we're in the performance year. I think, still be paying attention to what might change, but you really can't wait until the end of this year to say, okay, looks like I'm going to have to report eCQMs or MIPS CQMs or Medicare CQMs. Like maybe I should start figuring out what that entails. Like it is, if you are not already planning for this and getting the right technology in place and the right supports in place to do the reporting, but also to improve performance, you're behind the ball. So keep an eye on those changes, but you got to keep working on this now.
And again, the better you get at this, it's a lot different than the old process. So getting it right, having an opportunity to dual submit if they do extend this, and just having some runway, to see how am I performing if I were to submit right now. Where are my challenges? How can I most easily address those? So there's never enough time in the day. Which, Garrett, if you're still monitoring, we have poll question number 2. Would love to get a little bit of audience feedback on this subject.
All right, I'm pulling it up now, and you should see it on your screens. Go. What is your biggest concern for the PY 2025 MIPS reporting period? The ability for my providers to accurately document in there. Oops, and I think that question got a little cut off here, so I'm going to read that question. One moment here. Sorry about that. Working live here, folks. We do have word counts on there, and sometimes it doesn't match up. But let me pull that question up for you real quick. Okay, polling question 2 here. Sorry about this, guys. All right, so what is your biggest concern? The question A is the ability for my providers to accurately document in their EHR. EHR is what is missing from that. And then the others are all there. So apologies for that.
This may not be for everyone on the call, specifically provider groups and obviously ACOs, but so we may not see as many responses on this one as the last, but.
Yeah, I think most of the responses have come in at this point. And again, that first question was the ability for my providers to accurately document in their EHR. So I'm going to go ahead and close it down in about 5 long seconds here, and then we will show the results. And in 5, 4, 3, 2, and 1. Okay, Maria.
James, the winner here is all of the above, which I would say I don't feel surprised by.
No.
But all of the above followed shortly by ability to extract data from all my providers.
Gotcha.
For the winners.
A similar question to the first, and I think again echoes some of the things that we've talked about. So we haven't changed anybody's mind yet, but that's okay.
No, you should be concerned, not concerned in a way where you can't overcome it, but like this is a big deal and you got to be preparing for it. So
understand the risks exactly. Well, we have one more, I think, subject before we get into Q&A. So I hope we haven't lost anybody and you continue to stay with us to participate in some of that conversation and dialogue as well. Um, we want to talk about some potential changes to MACRA. And for those of you that are unfamiliar with MACRA, of course, we deal with a lot of acronyms in healthcare and specifically in value-based care. So MACRA stands for Medicare Access and CHIP Reauthorization Act, which began in 2015. So we're about 10 years in, and ultimately what MACRA is Medicare looking to better incent quality in terms of their payment model. So that launched the QPP, or the Quality Payment Program, which has two different arms associated with it. The MIPS program, which is the merit-based incentive payment system, as well as APMs, or the alternative payment models. And of course, within that is the ACO REACH program for those ACO organizations, as well as MSSPs. Things that, again, current state, what are your thoughts, Maria, on where we are right now and sort of some of the things that we might see as we move forward?
Yeah, mention a few things here. I think on the advanced APM side, starting there, for folks that are, on the webinar today and have been operating a REACH ACO or participating in a REACH ACO or one of the more advanced tracks of MSSP, so level E or enhanced, you're probably pretty familiar with the advanced APM and the QP status implications. And I would guess that most of you have been paying attention to the fact that the APM incentive payment, that lump sum bonus that has been available in prior years for organizations or for providers that are participating in ACOs and other models that have downside risk. You're probably pretty familiar with that and familiar with the fact that it's not currently authorized for 2025 or any later years. So unless Congress takes action there, there won't be that lump sum payment. If you're a QP, there are still some potential benefits. You're exempt from MIPS, so you don't have the reporting burden there. But keep in mind there that means you also aren't getting a MIPS adjustment. So you're getting a little bit of a bump on your physician fee schedule conversion factor, 0.75 instead of 0.25. But that's pretty different than getting a 5% or a 3.5% or even a 1.88%. I think that's where they ended up with the APM incentive payment. So that's something to watch for, is whether Congress extends the bonus payment. But I think another thing to focus on there is the fact that the QP thresholds are set to increase in 2025. And so I often come across folks who have the impression that just being in a REACH ACO means you're exempt from MIPS, but it's, as are many things in the regulatory space, more complicated than that. So you have to be in the model, but then there's this threshold you have to pass to actually qualify as a QP, and those thresholds increase in 2025. So unless CMS freezes the thresholds at a lower rate, which they have done in the past, we could start seeing some ACO REACH providers or MSSP providers that are in those advanced tracks but actually aren't qualifying as QPs. Now, if you're performing well in MIPS, then maybe that's a good thing. You get your MIPS adjustment and you're happy about it. But if you are a provider that's never really been subject to MIPS, you've always been in one of these advanced APMs, and that's going to be new for you, that's something to be on the lookout for. So that's, it wouldn't surprise me if we see some legislation related to MACRA this year. It could be a whole overhaul of MACRA that would probably take longer to implement, or it could just be sort of some tweaks along the edges that gets thrown into a continuing resolution spending bill or something like that, where they're extending, freezing the thresholds or extending the bonus at some rate. But if you are if you're not paying close attention to what's different in 2025 without congressional changes, I would take a look at some of those so that you can be prepared if Congress doesn't take action to extend some of the things that have been in place before.
What goes into those thresholds? Like, what is that based on volume of Medicare beneficiaries?
Yeah, so there's two ways that CMS calculates it. One is using Medicare revenue. The other is using what they call the patient count method. So like individual humans. And they're looking at if they're doing it at the ACO level, they're looking at all the providers that make up the ACO, and they're going to look at either the revenue or the number of patients that those providers see in that have Medicare fee for service. So not who's attributed, but like who do you see overall? Who have you had encounters with? And then they're going to look at the portion of that total that is attributed to and seen, attributed to the advanced APM, so ACO REACH or MSSP, and seen by a provider in that program. And so it's a little bit tricky to follow and it can feel kind of convoluted, but the basic concept is that they don't want to be giving you this bonus if you're sort of just dipping your toe in the water of value-based payment. If most of your revenue is fee for service and you don't have those patients in value-based arrangements, then they're like, no, you're not really eligible for this. And so in prior years, I think for 2024, the thresholds were you had to have at least 50% of your revenue or 35% of your patients. And you don't have to meet both. It's one or the other. So 50% revenue, 35% patients tends to be easier to meet it on the patient count side for most organizations. But in 2025 and beyond, those thresholds are scheduled to increase to 75% of revenue or 50% of patients. So you should be able to, if you are an organization that's been in one of these programs for the last couple of years, you can actually go into the QPP portal and you can pull down prior year reports, and it won't just tell you, did you meet it? It tells you the percentage that you were at. And so that's not a guarantee of what it will be, this year, but it can give you a sense of like, oh, I was safely well above the 50% patient count, or, oh, I was at 40% patient count and that was good enough last year, but it might not be good enough this year. So that's a good way to start, at least to get a sense of where you were in prior years.
Very cool. Very educational. Thank you for that. We have a couple of more minutes, I think, before we get into Q&A. And, one of the things I wanted to spend a little bit of time on is, again, something I mentioned earlier, is the access to data and the challenges we have unifying data for the purpose of providing better patient care. And something that I think is maybe not as urgent, but has been talked about for the last couple of years and will continue to, I think, to be more of a focus as we move forward, is health equity type of metrics and social determinants of health. One of the challenges I think we have in healthcare at the provider level is the fact that there is so much data out there, yet we don't always have access to it when we need it. And oftentimes when we think about, the factors that determine factors that determine health, as well as, potential for having challenges, those aren't things that your EHR necessarily has a good place for. So I'm kind of skipping forward here just to kind of get to this slide. But, where I think in my conversation with you prior to the webinar, Maria, we talked about how ACO REACH may be backing off of utilizing health equity metrics in order to kind of measure, how well we're doing with respect to disparities in care and availability of care and things like that. But kind of going back to what I was mentioning earlier is, there's all this data out there, and we know that much of this data has a bigger impact on patient outcomes than even the actual care that we're providing within the four walls of a practice. But when is that information helpful, and when should it be utilized? Are the things that I think are going to be the most challenging going forward in terms of implementing this data within a practice environment. Socioeconomic factors, how far is my healthiest food option from my house? Do I speak English? Do I have family support to help me through this care journey? These are all things I think that are going to continue to be a topic for this administration and for years to come. And anybody that wants to be really, really great at value-based care certainly are already utilizing these factors, whether it's in a standardized way or not, in order to determine, again, how best to treat a patient, what are the resources that they most require in order to, maintain a healthy lifestyle. So again, kind of short on time. Maria, love to hear any comments that you might have on that before we wrap and move into Q&A.
I think what you said is right. We may see less of a focus or less use of, terminology that we've become used to in the last, 5+ years around focus on health equity or health related social needs, social determinants of health. But I think anybody that, um, you know, any primary care provider that's, working with patients, any, community-based organization or folks working in the space knows that it's more than just the healthcare you receive that affects, your health. And so if we're thinking about, better patient outcomes and we're thinking about, how to be successful in value-based programs, the need to think about what happens outside of, the doctor's office or outside of the sort of traditional healthcare space is going to continue to be important. And so I think that's important in how you think about delivering care, but it's important also in how you think about the data that you're storing in your system and how you make sure that you can tap into those sources and document beyond what we might traditionally be used to documenting when we think about medical care. So
This is the stuff that I always think that nurses have historically just been so good at, and they keep a lot of this information in their head. But, if we're going to be measured on it and looking at metrics associated with how we're addressing or improving these factors, like you said, the documentation part of it is going to be, something that we have to focus on more and more over time. So with that, Garrett, we'll probably skip this third polling question in order to get into Q&A. We have 12 minutes. Would love to get back on the audience whether there's questions or
All right. Very good. Well, we do have a number of questions, and if you do have one, by the way, that you would like to submit, go ahead and use your control module as an attendee. There's a place specifically for questions, so drop those in there, and we're going to get to as many as we can. I know we're a little bit limited on time. First question here, in no particular order, is what do you believe is CMS's role in standardizing healthcare data from EHRs to make it easy to aggregate data and coordinate care?
That's a good question. Maria, I'd love to get your thoughts on it, being that you'd spent some time at CMS yourself. But I think that's one of the things that, since I've been in healthcare, is the government going to get involved and require vendors to standardize, how they communicate and make that information more easily accessible. I haven't seen it so far. I think that there's only so much that they can do. I personally don't expect that there will ever be legislation that forces vendors to make it easier to transfer data. But again, Maria, that's my opinion. I'd love to get your thoughts on that.
yeah, I think we've certainly seen this is less in the CMS side, but under the sort of broader federal government umbrella, ONC, the Office of the National Coordinator for Health IT, is where we've seen most of this regulation come from in the past in terms of meaningful use standards and, the 2015 CERT criteria and things like that. But, and I think in some sense those have moved things forward, but they're not, we're not at interoperability, right? We are not at standardization across EHRs. And I think with some of the, ACO requirements and things like that, we're sort of seeing CMS try a different approach, which is like create incentives or requirements for the private sector to then, in terms of provider organizations and things like that, to then put pressure around the vendors to deliver on that. But I think my personal view is like it's got to be both, right?
Right.
And different providers in that space have different ability to negotiate that. But I hope that we'll get there. I don't think it's an easy problem to solve in the private sector or public sector, but I think we probably need both regulation and and private sector money pushing for it, you know.
Agreed. And they have created like QRDA1 is something that I talk about a lot. It's a new file format which you know has more quality data than we used to have access to than other files that are often utilized like CCDAs and things like that. But unfortunately, it's just a snapshot of data. So in order to be current with what's happened most recently, you need to continue to get those files pushed out and then ultimately aggregating it with into a repository that allows for the use of that data for patient care. So, anyways, that's our thoughts on that, Garrett. I think
Okay.
we're getting there, but we're also limited and kind of constrained on what we can do to create that standardization.
Gotcha. All right. Moving right along. Next question here um, is so if an a reach ACO, let's see, if you're in a if we are in a reach ACO and you're not a QP, do you still have to report MIPS?
Yeah, so if you're in a REACH ACO and that ACO does not meet the QP threshold, you would then have to report MIPS. I should be clear that I'm not saying that REACH ACOs are no longer going to meet the threshold. I'm just saying there's more of a risk that they might not. So it's something to be asking if you're in an ACO, asking them for that information to try to understand the likelihood that the ACO will meet the QP threshold. And if the ACO does not, it's possible if you're in an ACO and then you're also in some other kind of value-based program with Medicare that you could still meet it, but let's assume you're not and you don't meet it through the REACH ACO, then you would have to report MIPS, and that can be a big undertaking. And unlike an MSSP where there's some advantages to, you can use the ACO's quality score and things like that. That doesn't exist in REACH. It hasn't really needed to because REACH ACOs meet the threshold, but yeah, my advice if you're in a REACH ACO today and you're not sure what that means is start asking the ACO that you participate in for some information about how close they were to the QP threshold and what their plans are to stay on top of that and understand what it is and when they'll communicate to you about the threshold. You can also there's a NPI lookup tool on the QPP website where you can put in your national provider identifier and it will show you whether you're a QP or not. For 2025, that CMS hasn't run those calculations yet, but in like July, they should be releasing the first snapshot. So you can also check yourself directly to see if you meet that. But if you want some information before that, I would ask your ACO sort of for the figures from last year.
Cool. And a follow-up question to that is, if you do have to report to MIPS in a REACH ACO, is that traditional MIPS or just the four CQM measures?
I think you might have I would have to double check, but I think you might have the option to report the APM performance pathway, which is those four measures. But keep in mind that MIPS is not just quality, it's quality, promoting interoperability, improvement activities, and cost. There's no active reporting for cost, but for those other ones you need to report. You would have the option to report any of the traditional MIPS measures you would want, but there's differences in terms of the scoring and how that works. And you wouldn't get some of the advantages of the APM performance pathway if you were reporting traditional MIPS measures.
Yeah. Great. Next question here is there any insight on a national event notification system that transmits ADP from hospitals to value-based companies to be able to coordinate transition of care? Florida has one. Are you familiar with this at all?
I've heard of some vendors getting into that space. I can't remember the name of them off the top of my head, but I believe it's a subscription service. I'm not familiar with any state-run or government-run program that would offer that, and I'm not familiar with the Florida one, unfortunately. Maria, do you have any insights on that?
Definitely vendors that do this. I think there may be some like state health information exchanges that might have this kind of functionality or where the like vendor runs through that, but I am not
Right.
aware of any national plans or programs around that. But certainly it's something locally that's happening.
Yeah.
Gotcha. This next question kind of piggybacks on our last discussion about MIPS, and it says, how do you find out if your ACO meets the threshold?
The ACO would find out through the QPP portal. There's reports that come out each snapshot period. So that's usually like July, October, December, I want to say. If you are an individual clinician or a practice, then you can use that public facing QPP, qpp.cms.gov. And there's right on that homepage, there's like an NPI lookup, and you can type in your NPI and see at least for, it'll show you for 2024 whether you're a QP, but it won't tell you your ACO's threshold score that you would have to get from the ACO.
Got it.
All right, next question, moving right along. What strategies can providers employ to address health equity disparities in their practices?
I'm sorry, was that what technologies?
What strategies can providers employ to address health equity disparities in their practices?
Well, one of the things that I had listed, I think on the slide, is the availability of multilingual resources within a practice, having maybe services that are going to make it easier for you to be able to communicate with, again, different people within your community. Maria, I'm kind of,
Yeah, I'm happy to jump in.
In my mind, yeah.
Yeah, I think the first thing I would say is like, you don't have to like start with a targeted area, like don't try to solve everything at once, but as an example, you could look at your, performance on quality measures and start, bifurcating that performance by, I don't think bifurcate is the right word there, but start dividing up that performance so that you can see like okay, here's my controlling blood pressure score. Like, what does that look like across different racial and ethnic groups? And so do I have an inequity there? And then what kind of strategy would I need to address that inequity? Doing that kind of thing requires that you actually have the race and ethnicity data on your, or language data or whatever on your population. So if you don't have those things today, I think starting there with like collecting data from patients to make sure that it's accurate. Often the payer data is not so accurate in this space, so direct from patients is a good way to go. But there's lots of great resources out there on what different organizations are doing, and I think it really depends on the communities that you're serving and your specialties, the size of your practice, sort of where you want to start. But I would say don't let the like perfect be the enemy of the good here, right? Like find something that you think you can change and start working on changing that, whether that's multilingual resources or addressing housing or addressing, food insecurity or something. You don't have to bite it all off at once.
That's good
That's really
advice.
well. Yeah, it's a good way to end it.
Yep, and speaking of ACO resources, we are out of time, unfortunately. Which, by the way, if you have a question that didn't get answered or you still want to ask, go ahead and drop that question in now. Someone will reach out to you via email later on. So go ahead and do that, even if we're just wrapping up. But I know James is putting on the screen here some additional resources for ACOs at the MRO website.
Yep. So these will be available via the presentation that gets sent out. But on the MRO Corp website, you'll find a lot of different resources pertaining to value-based care organizations, whether it's blogs, podcasts, and different things that we've made available. So would encourage people to visit that. And obviously coralhealthadvisors.com, where Maria also has lots of great information and resources, and could be a resource potentially for some of the people on this call should they reach out to her as well. So very knowledgeable, and again, appreciate Maria your time and participation in this webinar. So
great talking with you as always, James. Thanks for inviting me.
Yeah, thank you both. This is a fantastic presentation. And as we wrap, wanted to encourage you all to head over to vbcexhibithall.com and check this out. MRO has a virtual exhibit booth there, and there's a link directly to it in the slides that we're going to send. And you can, it's kind of a snapshot of what they're doing in the space. You can read up on them, really familiarize yourself with what's going on, what they're into. Obviously, contact them through there, but really just kind of educate yourself. There's also a lot of wonderful resources on vbcexhibithall.com in the library archive, all kind of different articles and webinars and white papers, which is actually where this webinar will be archived. So if you wanted to check that out later or see some of MRO's other stuff, or a lot of different varieties of topics, head over again to bbcexhibithall.com. And then as we close out here, if you'd like to reach out directly to the MRO team, feel free to do so. Yeah, there we go. There's James and or Maria. Their contact information is both on this final slide. Again, we're going to send out a link or to where you can download these slides, so this information is on there. But feel free again to reach out to them directly or to me, and I'm happy to facilitate an introduction if that's easier for you to do so. But wanted to thank you all again so much for joining us today. Hope you come to see us again in the future on a future session. And until then, have a great rest of your day. Bye-bye now.